Good day, Hudson Valley. I'm your host, Lisa Caslin, and welcome to our show where we bring you the best of what's happening and who's happening in Putnam, Westchester, and Dutchess. Today, we're going to end our four-part series on community behavioral health with a discussion about veterans' mental health and some of the stressors that they're experiencing when they come back home. We have a panel of expert guests today, and I'd like to introduce first Carl Rohde, who's the director of Putnam County Veterans Service Agency. Welcome. Jessica Mizuko, who works with Carl, and she's a coordinator of Veterans Services for the Mental Health Association. Welcome.
Thank you.
And Jessica Granger, who's a vocational specialist for the PROS program at Putnam Family and Community Services. Thank you all for coming.
Thank you.
Carl, I want to start with you. I was doing some reading, and I was on the VA website, and I was startled by some of the statistics that in New York State alone we have almost 900,000 vets in our state, and I know that there's also been a lot of reports commenting on the lack of care, or the VA is just not able to keep up with the need for mental health services for these guys. So what do you think is going on? Why do you think it's so difficult for us to provide the treatment that they need?
Well, I think the numbers alone, 900,000, we have a limited amount of VA hospitals. Sadly, not every VA hospital deals with mental health. VA hospitals set up specific goals. Mm-hmm. In our area, Montrose deals with post-traumatic stress. Castle Point, which is our other VA hospital, doesn't. So it has to do with logistics a lot of times. A lot of it is underreported. Veterans don't report that they're having problems. They try to deal with themselves. That's what they were taught in the military. Mm-hmm. Deal with the problems that you have and move on. Right. So I think a lot of it is and I don't want to say the macho, but because I don't think that's what it is, but it's the self-preservation.
Suck it up.
What you were taught. Yeah, I think that's a lot of it.
So if you were to do an appraisal yourself, what would you say how are they faring in general, and what would you say are the biggest issues for them right now?
I think the single biggest issue that we're dealing with as a nation, and impacting both veterans and active duty military, is the suicide rates.
Yeah.
22 veterans a day are committing suicide, and it's not just the recent veterans, it's veterans going back to World War II veterans are also, and we have to get a handle on that. An interesting statistic, there's, with Afghanistan war still going on, mm-hmm. the more service members died of their own hand than died in Afghanistan in the last 2 years, each of the last 2 years. And that's sad. And we've got to not only get a handle on the why, we've got to get a handle on how can we prevent it. And that's not easy. It's a daunting task. Oh, yeah. But we have to work on that.
Absolutely.
So I would say that's the biggest issue right now.
So I know that you have recently been, I guess, promoted, if you will, in your capacity as full-time director, right?
Right, I'll be the full-time director for Veteran Services
in Putnam. So what is your office doing specifically to support these vets, and how are you helping them?
Well, we're going about it several ways. First, I just want to say one thing, and I think there's a great misunderstanding of post-traumatic stress disorder. Mm-hmm. Post-traumatic stress disorder is not what's wrong with a veteran. It's not what's wrong with me. Mm-hmm. It's what happened to me.
Okay.
And I think that's a distinction that we have to make. Back in the Civil War, post-traumatic stress, they've had it forever, mm-hmm. but it was called soldier's heart. Oh, okay. And I think that's a lot better way to think of it, that mm-hmm. There's some sort of change, we don't know what it is, mm-hmm. and we have to deal with it, rather than a stress disorder. I just think that has negative connotations. My office is trying to become proactive in the community. We have, my deputy and myself have trained recently to give Safe Talk suicide. It's not
prevention.
It's more well, not even really prevention, but to be able to recognize when somebody may have stressors for suicide. Okay. It's not an intervention yet. It's just where I'd be able to talk with somebody and say, wow, this person may be contemplating it. So that's one way that we want to train more people to take the Safe Talk classes. Mm-hmm. We also are doing a lot of outreach, going out, asking the veterans what they need, where the problems are, trying to get them into the in for help into our office to get their paperwork done so they can apply for their entitlements and their benefits. So I think it's a lot outreach, awareness that we actually exist. Up until a few years ago, people may not have known that we had a veteran service agency, and we can't do that anymore. We have to be proactive. We can't wait for the veteran to come to us. We have to go out and seek them out.
Yeah,
for
you
their
have
help.
to market yourselves.
Correct.
Right?
Yep.
So I think that one of the steps that you're taking, which I think is very positive, is to implement this program, right? Talk about that, the peer-to-peer program that you're
It's the
working.
Joseph Dwyer peer-to-peer program. Yeah, I'm working with MHA on this. We contracted with them. Joseph Dwyer was a Iraqi veteran, iconic picture of a fully geared veteran carrying a fully geared active duty Iraqi veteran carrying a little baby to safety. And that was Joe Dwyer. And Lee Zeldin, who was a senator, he's still senator, will be leaving office this year, was a friend of his. And he said, we've got to prevent this. So he thought that peer-to-peer, one-on-one talking, veterans helping veterans would be the best way to go about it. And he put together a program where 11 counties throughout the state are getting funds to run peer-to-peer. And what we have done is we contacted MHA, and they had an idea. Well, actually, they contacted us, and they had an idea to do these warm lines where a veteran or a family member can call up just to talk to somebody, not for clinical help, but just to talk to somebody. So, and we're calling it vet to vet, but it's still the peer-to-peer. It's veterans helping veterans. And we've started training in that. And again, what my office is doing besides that, both my deputy and myself are trained to go in if they have a day where the people that are answering the phones can't come. Either Art or myself can go in there and we can fill in as a call, to receive calls.
That's great.
And help the veterans.
Great. So Jessica, talk about your end of this. So you are doing the implementation. You're actually
Yes.
managing the program,
Yes.
and you're working with the vets who are acting as peer counselors,
Yes.
basically, right? So how is that going? What's the rollout been?
So far, so good. I think we definitely need our veterans in Putnam County to, kind of step out. There was a survey that was dispersed into the community about a month ago, 2 months ago, and the primary result was that veterans in Putnam County needed assistance with VA and access to health care. So what we are trying to do as a team is kind of respond to the community. What do our veterans need? Some veterans don't feel like they can go to the VA, so that's why we have this peer-to-peer program, so they know that they're not alone in this process.
That's good. So, I'm sure, peer-to-peer, the whole philosophy of peer-to-peer has
Yes.
been around for a long time.
Yes.
I think, in particular, and you touched on this before, this particular demographic really struggles with, admitting to,
Sure.
this, that they're having issues, that, they're having some kind of difficulty, and they probably don't like to say that they need help. Why do you think it is more acceptable to them to talk to, a former vet or a buddy than it would be to maybe a more traditional counselor?
Sure. There's clinical research that shows that when you have someone that has experienced the same type of trauma that you have, there's this feeling, I can't describe it. I've been in it many times where I'm having a bad day and someone else said, hey, I've been through that, so I know what it's like. There's something about that just creates this powerful connection that opens the doors, versus someone who's clinically trained may not have been through that traumatic experience, really doesn't know what to say. As a social worker, I can tell you that I have been trained on how to respond, but it's not the same when you speak to someone who has, sustained the same experiences that you have.
Yeah.
So it's a very powerful, that same boat phenomenon is a very powerful movement.
Yeah. So Carl mentioned the crushing numbers associated with suicide in
Yes.
this community, and also, post-traumatic stress disorder.
Yes.
Is there anything in particular, during this training, how you're working with these peer counselors, how are they able to really work on those two particular issues? What is it that they're...
So we do a couple of different things. One, we have our peer specialists who are ambassadors, and they are veterans, so they are answering the phones. We are creating different workshops, lunch and learns to talk about post-traumatic stress disorder, and things of that sort. You know, there's a solid statistic, I'm not sure what it is. I want to say it's above 56% of active duty members that when they come back to the United States, they don't return to their origin, to their original communities. So most of these individuals are stationed somewhere else with no support system. So you wonder why the suicide rates are so high. It's very important that we develop these supportive environments for our veterans to help with the treatments of post-traumatic stress disorder and for suicide prevention.
Yeah, I agree. So I know the MHA is excellent at reaching out and providing resources, you know, mental health in particular. When it comes to you know, an instance where you might, one of your peer counselors might encounter somebody who, you know, really may look to do harm to themselves or others.
Yes.
What's the next step there? How do you then transition from, you know, the services that you offer, and then maybe you don't offer those services? How do you handle that continuum of care?
Right, so our program is not clinical, so we have developed relationships within our community to clinical services. So for us, you know, our closest relation would be Putnam Family Community Services. So again, our ambassadors, our phone specialists are trained to deal with a situation in which if someone is going to harm themselves through the assist and the safe talk trainings that Carl has provided. However, if it comes to a point where the ambassador does not feel trained, then we do refer them to Putnam Family or a program that we know is veteran specified.
Veteran friendly, right?
Yes, veteran friendly.
Yeah,
yes.
great. Thank you. So, Jessica Granger,
Yes.
you're with Putnam Family and Community
I am.
Services. And I know that your agency is sort of reacting to, you know, the void right now. And I wanted you to talk a little bit about that. How are you gearing up to help vets?
So Putnam Family and Community Services at this given point knows that the veteran population is growing, and we want to make sure that we're offering appropriate services and appropriate level of care to really address some of the needs that are getting conveyed. So right now our staff was trained, we took an online training course that specifically caters to situations that veterans would have endured. Because us not having actually gone through the experience of what a veteran had endured, we need the educational component of it. So by taking this online training course, it walked us through different facets of what a veteran may have encountered or endured, which better prompted us to address some of the needs that they may come to us, mental health-wise or otherwise.
So it's as simple as, you know, I'm a vet, I'm feeling like I need some help, I come in. I don't necessarily want to talk to somebody who doesn't understand my background and then have to rehash that whole experience, right? So that training basically sensitizes the clinician to all of that, and they can kind of, yeah.
Absolutely, we feel more empathetic towards it. We have more of an understanding as to what's really behind this, what's facilitating this mental health system, or what's facilitating this void, so that we can better appropriately address it.
That's great. So I want to make sure that we put up a graphic for more information. I think we have all your website addresses, and most importantly, what is the number for the peer counseling, vet to vet?
Yes, the warm line number is 845-278-VETS, so that's 8387.
Great. And is that a 9 to 5 number? Is it 24 hours? Is it?
It's from 11 to 4, Monday, Tuesday, Wednesday, and Friday. And on
Okay.
Thursdays, we're open from 11 to 6.
Okay, perfect. Anything else you want to tell the audience that you think is important? Anything else that the vet should know?
I would say the thing is that vets are regular people in your community. You may not even know who is a veteran. Ask a person if there's a veteran. Sometimes people say it's window dressing, but you know, go to veteran ceremonies, go to Veterans Day, go to Memorial Day. Don't treat them as a holiday. You know, attend them and meet some veterans. Talk to them. We're pretty much regular guys. I know the VA down in Pittsburgh just had a seminar to get their people to understand veterans better, and they depicted veterans as Oscar the Grouch, which I think was a pretty negative way to do something. But we're not. We're just regular guys in the community, and
Yeah.
talk to us, guys and girls. I get yelled at all the time.
Yeah. We appreciate everything that you've done. I think we're about out of time.
Okay.
But thank you so much for joining,
Thank
and have
you.
a great day, Hudson Valley.